Dr. Agarwal, can you hear me?
Yeah, I can hear you. Should I get started?
Yeah, so let's do the introductions first, and then I would like to welcome all of you on behalf of AAPI. This is the first CME meeting of the year. So we are excited to present a series of webinars this year, and this is the first one. And we have a very distinguished CME committee, which is chaired by Dr. Amit Govil, who is the president of Indian Nephrology Nephrologists of Indian Origin, American Nephrologists of Indian Origin, ANIO, and he's from Cincinnati. He's the head of the Department of Nephrology there. And so many accomplished physicians are joining us today. In the committee, we also have Dr. Bharati Kurana, Dr. Anjali Gulati, Dr. Manmeet Ahluwalia, and Dr. Brahma Sharma. So these are all the distinguished committee members. So Dr. Amit Govil, please take over. You are the CME chair. Thank you.
No. Thank you, Dr. Katula, for giving us this opportunity, and we look forward to a wonderful year of CME presentations. So it gives me a great pleasure to introduce our first speaker for this webinar year, Dr. Rajiv Agarwal, who is an emeritus professor at Indiana University and a practicing nephrologist at Rodebush VA Medical Center, Indianapolis. He earned his medical degree from the All India Institute of Medical Sciences in New Delhi, has published over 450 original papers and reviews in nephrology, numerous invited lectures at major universities, national and international kidney, diabetes, and cardiovascular organizations. But his foremost contribution has been hypertension and chronic kidney disease and ESRD patients. He has been continuously funded since 2003 by NIH, and he's also the recipient of the Clinical Excellence Award by the ANIO, or the American Nephrologist of Indian Origin. And very recently, he's a recipient of the Clarivate Highly Cited Researchers in the Field of Clinical Medicine 2023. And this is a very coveted award given to authors who have their highly cited papers that rank in top 1% by citation for the field and publication year in the Web of Science over the past decade. So this is truly a very accomplished journey that Rajiv had. So we just wanted him to share some words of wisdom from him about hypertension, a primer for primary care medicine for chronic kidney disease. Welcome, Rajiv.
Thank you, Dr. Govil, for inviting me to give this lecture to the AAPI organization. I'm going to speak on hypertension and chronic kidney disease, and it's really a primer for primary care. Here are my disclosures. I'm going to talk about the prevalence, pathogenesis, about hypertension-CKD connection, guidelines, and finally, how do you manage your patient with CKD and hypertension. Prevalence depends on many different things, but it's mostly definition. For example, if we go by the old definition, 140 over 90, which is KDIGO 2012 definition, the prevalence is 50% in CKD. And if you go by the newest definition, which is KDIGO 2021, which defines hypertension as 120 or more, it's 70%. And if you go in between, which is the AHA ACC definition 2017, 56%. So this is no surprise. The lower you make the blood pressure, more people will be hypertensive. Now, there's not just that. There's a lot of variation in blood pressure control across the world. These are 17 different cohorts around the world, 34,000 patients. All of them have chronic kidney disease. And if you look at blood pressure more than 130 or 80, which is the AHA definition, the best center has only 54% of the patients controlled. The worst center, 84% have no control.
Rajiv, 1 minute. I think we can't see the slide. Seems like they're not projecting what I've been told.
Okay.
Yeah, I'm not seeing the slides.
I'm sharing my screen on the Zoom. Help me figure out.
So maybe the admin can help and advance the slides for you and take the control.
I'm basically share.
Yeah, now we are able to see.
We can see your desktop.
Okay. All right, then I will share the other thing.
Just saw your desktop, but again, it
Yeah.
yeah.
I think you should be able to see
Yeah.
it now.
Okay, now maybe just, yeah.
Can you see it?
Yes, we can.
Okay, good. So blood pressure control, really the worst center, 84% of the people don't have any control. Now, if you look at around the world, we have a lot of variation. India also had a cohort called ICKD. And if you look at India, the number of people who have poor control is actually quite high. Not very surprising. We don't have very good procedural ways to manage blood pressure in these people. So the hypertension is quite poorly controlled in India. But suffice to say, there's substantial heterogeneity in how people treat hypertension around the world and how people prescribe medications. For example, in Asia, there's a lot of ARBs used, but very little diuretics. In United States, there's a lot of calcium channel blockers being used. Now, when it comes to kidney disease, we often teach that the lower the kidney function, the poorer the blood pressure control. But that's not true if we account for proteinuria. In fact, if we look at proteinuria, it's a stronger determinant of blood pressure in CKD than GFR. In other words, if you just look at dipstick proteinuria or you look at urine albumin to creatinine ratio, it's a much stronger determinant of hypertension. And we discovered this about 20 years ago. We looked at a cohort of veterans, 232 veterans, and we found that it's the protein to creatinine ratio that's the strongest predictor, not GFR. And on this slide, if you look at the correlates of hypertension, you see the proteinuria is the strongest correlate. It's right here on the left, and you can see it's the strongest correlate. Thus, using routine blood pressure, if we standardize the blood pressure, it's even stronger. Home blood pressure, even stronger, and ambulatory, the strongest. In other words, it's proteinuria, which is the determinant of hypertension. And turns out that if we look at GFR, it didn't even factor into a determinant of blood pressure control in these patients. Let's move on to pathogenesis. Why do people with chronic kidney disease have a lot of hypertension? The same factors, sodium excess, vasoconstriction, impaired vasodilatation. But very important, we now have access to a lot of street drugs, things like cocaine and amphetamines, and things we don't even know about, like Clarity, Biscuit, Doug, Hug Drug, Lover Speed. I mean, they're crazy names, but there are a lot of people who are using these, and they often come in very hypertensive into the emergency room, and we are scratching our heads and we are trying to see if they have secondary hypertension. They might simply be using street drugs. But even the prescription drugs may be quite important. 3 of the drugs that we encountered in nephrology quite frequently is cyclosporin, erythropoietin, non-steroidals. They're very common. And when we look at the broader internal medicine group, it would be steroids, and oncology, VEGF inhibitors. So if somebody is getting sunitinib and drugs like that, they can be frightfully hypertensive when they receive these drugs. Now, we typically think the kidney as an detoxifying organ, but very few people look at the kidney as a giant nephron. And it turns out that the kidneys have afferent nerves, and a failing kidney will trigger the sympathetic activation. The signals go to the brain and lead to vasoconstriction. And the sympathetic activation in patients with kidney disease is quite an important way of causing hypertension. Well, CKD often is required for the development of hypertension, and I'll display it with this experiment in rats in which they undergo nephrectomy. So we are making them have kidney failure. Half these animals get EPO, half of them get sham vehicle. And the same rats, they're sham operated, so kidneys are not removed. Half of them get EPO, half of them get vehicle. Now, what would happen to hemoglobin? Of course, hemoglobin would go up. If you give EPO with vehicle, nothing happens to hemoglobin. But let's look at what happens to systolic blood pressure. Nothing when vehicle is given. Nothing when vehicle is given, even though they have 5-6 nephrectomy, they don't get hypertensive. And EPO without a nephrectomy, the blood pressure is controlled, but you give them EPO with nephrectomy, the blood pressure goes through the roof. They have about a 38 millimeter elevation on average when they have a nephrectomy and EPO. And we know this from our situation in kidney patients and comparing them with athletes. For example, oftentimes cyclists dope erythropoietin and they don't get hypertensive. Or patients who are on cancer chemotherapy, when they don't have kidney disease, they don't get hypertensive. But if you give EPO in a CKD or dialysis patients, often you can see hypertension. Now, let's talk about hypertension-CKD connection. We all think that CKD causes hypertension, hypertension causes CKD. So what is this conundrum? Where are we in 2024 regarding this thinking? First, let's look at CKD as a cause of hypertension. And the best data for this come from injuries that are produced to the animals. For example, you take a rat and subject it to a mild kidney injury in a time-limited manner. And how can you do this? You can infuse angiotensin 2 for 2 weeks and then stop it. Or give them phenylephrine for 8 weeks, then stop it. Or you can give them low potassium diets and cyclosporin, and all of them will produce kidney injury. But it's a time-limited kidney injury. You have injured the kidney, then you remove the injury. And what happens is these rats develop salt-sensitive hypertension following the injury. So here's the cartoon explaining this. This is a normotensive animal getting angiotensin 2. It's arrested, and then it undergoes a renal biopsy, which shows interstitial disease and renal arteriolopathy. It's then placed on a high sodium diet, it gets hypertensive. If it's on a low salt diet, normotensive. You take a normotensive rat, give it high salt diet, it remains normotensive. In other words, the high salt diet is dangerous. When you have kidney disease or subclinical kidney disease, that's when you get hypertension. Well, let's talk about hypertension as a cause of CKD. Well, first of all, association of hypertension with CKD is well known, and perhaps that's best clarified by the Mr. Fit study, which was published in New England Journal in 1996. And what it shows is the adjusted prevalence of ESRD. The association is that as blood pressure goes up, the incidence of ESRD goes up. But as we all know, association is not causation. Is it causal? It's not clear. For example, if you look at animals who have hypertensive nephrosclerosis, look at hypertension in animals and compare them to histology in humans. In humans, basically you get hypertrophied, solidified, ischemic, obsolescent glomeruli. That's the hallmark of hypertensive damage to the kidney. But you look at all the models of hypertension in animals, only one model has it, which is the Goldblatt rat 2 kidney 1 clip model. That means that you have to actually damage the kidney to actually produce this situation. But if you simply produced angiotensin 2 infusion, etc., you don't get the histology in the animal. The second group of evidence comes from the data that's generated by Dr. Bedu. And he asked the question, can lowering blood pressure prevent CKD? In other words, you don't have chronic kidney disease. I treat your blood pressure to a lower level, and can I prevent incident chronic kidney disease? And he looked at the SPRINT trial, about 6,700 patients, a CORE trial, 4,300 patients. And he defined CKD as more than 30% decrease in GFR plus a GFR less than 60. And what he finds is that blood pressure lowering actually increases the risk of incident CKD. You can see the incidence of CKD in ACCORD. It's much higher in the ACCORD standard in the purple, it's lower. SPRINT intensive in the blue, much higher. In the green, SPRINT standard, much lower. In other words, the story seems to be going in the opposite direction. Lowering blood pressure is increasing the risk of incident CKD. And the incident CKD was increased in each of the two trials, SPRINT and ACCORD. So we don't really have good evidence that blood pressure causes CKD. However, we have limited data to exclude this possibility. So what do I mean by that? Well, first of all, hypertensive retinopathy. In hypertensive retinopathy, the ophthalmologist will tell you by looking at the retina, this is hypertensive retinopathy. So it's possible and plausible that long-standing hypertension injures the blood vessels in the kidney just as it does in the eyes, damage to the arteries, that is stiffening and atherosclerosis. Cerebral vasculature is also well known. So besides the eye, it's also seen in the brain. So is it possible that the kidney itself might be the cause of hypertension, which subsequently leads to its damage? So this is a very interesting question, and it emerges from finding the APOL1 associated kidney disease. It's basically a situation where the kidney gets inflamed, and in the high interferon states, APOL1 culminates in podocyte injury via several intracellular processes. So this is a protein expressed in the kidney that leads to its damage and culminates in hypertension. Dr. Girish Nandakarni basically did the study and finds from a cohort of people in Mount Sinai's BioMe Bank and other cohorts that if they have this variant allele, APOL1 variant allele, they get hypertension quicker, sooner, a few years quicker, and eGFR declines a decade later if they don't have the variant allele. So in other words, it seems like the kidney is both here causing hypertension, but also destroying itself. What about blood pressure as a CKD modifier? In other words, you have chronic kidney disease. Should I treat your blood pressure to protect your kidneys? I've just said that, look, if I just lower your blood pressure, it's unlikely that you'll prevent kidney disease. But is it possible that I lower the blood pressure in a patient with CKD and I can prevent the progression of kidney disease? Well, if you look at the blood pressure trials, for example, the MDRD, ASK, RAIN2, and SPRINT, these are all trials done to test this notion. The answer is no, it really doesn't appear to be so, but there are exceptions. I'll come to the exceptions, but this is a meta-analysis published in Lancet a few years ago, and it shows that if you look at renal failure, what we call as chronic kidney disease, it neither helps nor harms. There's neutrality for kidney failure with blood pressure lowering. However, there are 5 pieces of evidence that suggest that proteinuria matters. In other words, you have CKD without proteinuria, blood pressure control may not be that important. But if you have proteinuria, it matters. I don't have time to go through each one of these studies, but this is a very nice study. It's done in children. And this is looking at progression of kidney failure in children with ambulatory blood pressure monitoring. One group gets intensified treatment, the other one gets conventional treatment, and they're looking at 50% decline in eGFR or receipt of dialysis. And what they find is that there's clear separation between conventional and intensified group. So if you have intensely treated blood pressure, these children benefit from having kidney protection. But what is more interesting is that if the children had proteinuria, for example, if they had glomerulonephritis, they had much more benefit. And if you just look at the baseline urine protein creatinine ratio, when they have a lot of proteinuria, they have the maximal benefit. If they have less than a half gram proteinuria, there's hardly any benefit. But if they have proteinuria, it benefits. So I think that kidney damage can be prevented in people who have proteinuria if they have strict blood pressure control. The guidelines are silent on this issue. Let's talk about guidelines and blood pressure targets. Well, there's a flurry of guidelines from 2012 to 2021, and you can see the earlier guidelines was less than 140 or 90, current AHA guidelines less than 130 or 80, and the newer KDIGO and Canadian guidelines less than 120. So the blood pressure targets seem to be falling. Well, how do we manage the patients if the guidelines can't agree what the level of blood pressure ought to be in our patients? How can we do a good job? Well, we have to recognize that we had electronic random number indicator equipment. This is ERNI. This was a massive computer that generated random numbers. Now, this was back in the about 50, 60 years ago. IBM used to have a whole room to generate random numbers, but now you see more familiar random number generating equipment. These are blood pressure monitors. They can generate random numbers quite easily if we don't measure the blood pressure right. And look at this way, which is not unusual, where people don't pay any attention to detail and simply measure blood pressure as if they're just generating a random number. So how should we measure blood pressure? Well, I tell patients very simply, do 5 things for 5 minutes before you check your blood pressure, and you'll get the blood pressure, which is really ideal. So then they're obviously asking me, what are those 5 things? I said, first thing is the time of the day. You have to be doing this first thing in the morning. When you wake up, you go to the bathroom, you have to empty your bladder. You can't have a full bladder. And then you're going to go to your dining room and sit on the chair with your back straight and feet flat on the ground. And you're going to put 2 cushions on your dining table so your arm is the same level as your shoulder. Put a blood pressure cuff on, and you can't turn on your phone because you need to now close your eyes and count 100 breaths. That's approximately 5 minutes. And when you are done, then you press the button, check your blood pressure, wait another minute and check another blood pressure, and just do it once a week. That's good enough because you have spent now 8 minutes checking a blood pressure, but a lousy blood pressure is a random number. And if you just do it once, that's very good. And the patients, half of them, they understand it. I just had a patient yesterday who was just arguing with me. Hey, why can't I check it in my recliner? Why can't I have my coffee when I'm having it? So some people, it's harder to explain, but many people will do it right. It turns out that even as doctors, we are not very good at it. Only 1 out of 159 US medical students from 37 states got the blood pressure measurement right in the study. So which technique is better? Standardized, which is sprint versus usual. So we looked at this issue, compared it with ABPM and left ventricular hypertrophy. We took a bunch of people and measured the blood pressure, and we took standardized blood pressure, and we found that the standardized way is much, much better and even almost beats ambulatory blood pressure if you do it right. Well, the second issue is that if we are really going to have good blood pressures done in our offices, you almost need a procedure room for blood pressure measurement. But if that's not going to work, home blood pressure monitoring is the way to go. And if we do that and we interact with the patients, I think we can really do a great service. So first of all, you're empowering your patient to take care of the blood pressure at home. essentially I tell my patients that, look, you take care of your car, but when the car goes bad, you can replace it. You only have one machine, which is your body here. You cannot replace it. You got to take better care of it than you take your car. Just like you document when you change the oil and the mileage and all that for your car, you got to do the same thing for your blood pressure, and home blood pressure monitoring will go a long way in establishing that, because it helps your kidney, it helps your heart. So the first step is education. The second part is engagement. You have educated the patient. The second is, hey, did you check your blood pressure? We talked about it last time. And when you do that, you affirm, because if they get you the blood pressure, you got to look at them. And taking an average is almost impossible. The way I do it is I just count the number of readings they have. Say, if they have 30 readings, I say 6 out of 30 are more than 130, which means the median has to be less than 130. They are well controlled. And that number, the number of readings outside range, the upper limit being 130, is a great way to affirm to the patients, doing a great job, keep doing it, and please keep a record of this with you. What we also find is that home blood pressure is prognostically superior to clinic blood pressure. So no matter how well you take a clinic BP, home blood pressures always beat. How do we treat these patients? Well, we've already talked about the education, the engagement, the affirmation. But, if we have to treat the patients, we really need to individualize. And when we are individualizing, we can't just prescribe medications. You have to tell them the salt intake is the other white poison, not just sugar, but salt is going to be poison, especially in a kidney patients, for the reasons we have just discussed. There's no safe lower limit for alcohol intake according to the World Health Organization. Alcohol is a toxin and can aggravate hypertension. Smoking, of course, we all know. Exercise, if you are younger than 60, 8,000 steps per day minimum. If you're older than 60, 6,000 steps per day. That's the threshold that's associated with the best health. If we see patients who are really fragile, and you have to kind of monitor them more closely, monitor their symptoms, eGFR, electrolytes, and get the blood pressure down gradually. You have to listen to the patient. Sometimes patients will tell you, doc, you prescribed me all these medicines. I looked over the internet. I take none of them because they have terrible side effects. So you're dealing now with Dr. Google, and you have to actually be sure that the patients follow your instructions. You have to educate them that, look, all medicines have side effects. I'm treating you so you can avoid heart failure, heart attacks, strokes, and kidney failure. So if you take it, that'll help you. The side effects I will monitor for you. So hypertension control is really a physician metric, because you have to make the right diagnosis. You have to use the right agents and combinations. You have to use the right monitoring, the right listening, and the right changes. And if we do that, if the patient is a player and you are the coach, hypertension control tells you how good a coach you are. And we need more good coaches for people with CKD. I'm going to stop here. Be happy to take any questions. Thank you for your attention.
Thank you, Dr. Agarwal, for that wonderful presentation. So anybody has any questions, please put them in the chat box, or they can raise their hand. And Dr. Brahma Sharma, who is a cardiologist from Pittsburgh, is a clinical professor, and he has been on many committees in AAPI, and he is the moderator, so he can moderate the session along with Dr. Amit Govil. Thank you.
Thank you. Good evening, Dr. Agarwal. That was excellent presentation. And as a cardiologist, I just want to make a comment that of all the global burden of cardiovascular disease, hypertension is the top culprit. And the global burden, as you know, is 1.4, 1.5 billion people. and almost half of the people do not even know that they have a hypertension. And a quarter of them actually are well controlled, what we call optimal blood pressure. So blood pressure is a global burden, economic burden, and a public health burden, and the primary cause of cardiovascular disease. Now, your comment about chronic kidney disease, I'm a little intrigued. Are you saying that the hypertension will cause chronic kidney disease only in people who have a proteinuria? Is that a, accepted narrative now?
No, I didn't say that. What I'm saying is that if we treat hypertension in people without proteinuria, it might not protect the kidneys. But if we treat patients who have proteinuria with blood pressure lowering, it'll protect the kidneys. We have now the SPRINT study, and which shows that even in patients who have a GFR less than 60, you can reduce cardiovascular mortality in those patients with aggressive blood pressure control. So my comments were focused on the kidney progression, and hypertension control can save the cardiovascular system in people with kidney disease for sure.
So you're saying primarily that it's not renoprotective in the absence of proteinuria, but it's protective for cardiovascular standpoint.
Correct.
Okay.
Correct.
Now,
and especially when you have heart failure, that can be very important.
I'm thanking for clearing that. Now, before I go to the next question, I have one question which is always there, in the kind of very conflicting statements from the nephrology colleagues that I work, and I'm sure everybody else on the panel and on this conference feels it. Like, when do you, there are two conflicting opinions here, that somebody has a CKD, should we continue ACE, ARB? Does that affect the overall progression of the CKD, or at some point we need to take it off? What is the latest on that?
So no question about this, that you need to continue ACE or ARBs for life in people with chronic kidney disease. This is particularly true, again, in people with albuminuria or proteinuria. If you don't have any proteinuria, there's no good evidence that ACE or ARBs can be protective for the kidney. To answer your second question, should we take these agents off? So somebody in UK did a trial, and it's called the STOP ACE trial. And half the patients, they stopped, half the patients, they continued, and there was actually no difference in the time to end-stage kidney disease. In other words, if you continued, their belief was that once your kidneys are so far gone, they are stage 4 kidney disease, so your GFR is about 30. If I take off ACE, you might get a few months of dialysis, and that was not true. So, you have to continue these drugs. The situation where you would stop these drugs is in a woman who's planning to be pregnant or a woman who's pregnant. ACE or ARBs would be absolutely contraindicated there. Or if somebody develops hyperkalemia, that's when you need to stop. So otherwise, there are very few contraindications to using these drugs.
Thank you so much. The first question I have is from Dr. Chandra Kanuru. The question is, please comment on the white coat hypertension and the risk of concomitant cardiovascular disease. So can you just, broaden out into white coat and mass hypertension and all that, how that is important?
Yes.
How does it
Very
relate?
good question. So white coat hypertension is when the patient comes to your office, the blood pressure is high. When they are at home, the blood pressure is normal. And we have known this for a long time. Approximately 10 to 15% of the patients have it. There's something now called white coat effect. In other words, the patient truly is hypertensive, but their blood pressure appears to be higher when they come to the office. Then there is the opposite. The white coat hypertension is generally a benign disease. But as you know, if you are 50 years of age, your lifetime risk of developing hypertension is 90%. So you have to monitor these patients, not like they won't develop hypertension, but you don't want to be treating white coat hypertension. And the way to diagnose it, the gold standard is ambulatory blood pressure monitoring, 24-hour ambulatory blood pressure monitoring. If that's not available to you, then home blood pressure monitoring would be a reasonable way to do it. provided the home blood pressure monitoring is done the way we are talking about. The opposite of that Dr. Brahma Sharma is talking about is masked hypertension. Masked hypertension is when the blood pressure is actually better in the doctor's office and higher outside. And there's a very nice study done in French private practices by Dr. Bobry. And what he found was that masked hypertension has a prognosis that is as bad as sustained uncontrolled hypertension, because these people are always running high blood pressure. Why does it happen? When they come to the doctor's office, it's very relaxing and they might be living very stressful lives. There might be also abstinence from smoking when they come to the doctor's office. You can't obviously smoke. There might be smokers at home, and there might be also chronic anger and chronic anxiety. They might also be contributing to masked hypertension. Nobody understands why we have masked hypertension, but everybody understands that it's important to identify and treat this condition.
So the
So
next,
there is,
next
Dr.
comment.
Sharma, I think we have a few questions. Dr. Gaurang Gandhi has been raising his hand. It must be hurting. So can we go to him? And then I think Dr. Alok Agarwal is the one who asked the first question in the chat box. I think let's go in that order. I mean, you are the moderator, so please decide however you want.
Okay, so in my chat box, next is Sudhakar's question. Dr. Sudhakar, General Gada, as you know, was an AAPI president. He wants to know comments from you about steps 8,000. Is it daily or 3 times a week? And does it help hypertension control in chronic kidney disease?
Oh, so there's no information on chronic kidney disease and hypertension, but this is a meta-analysis that's published in Lancet Public Health. And they look at the steps and the association with all-cause mortality. And they find that there is probably sort of a sigmoid curve. And what they show is that there's a age-related thing. So this is 6,000 steps per day if you're more than 60, and 8,000 steps per day if you're less than 60. So basically, you are given 2,000 steps bonus if you become older. But most of them are per day average. Of course, you can do it per week, but this is the meta-analysis. Again, these are associations, and it's often the case people who are walking more may also be the ones who are free of cardiovascular disease and who have a better social determinants of health. A lot of confounding factors, but these are the associations that we have seen.
Okay, Dr. Gaurang Gandhi has raised the hand. Please, Dr. Gandhi, go ahead. Unmute yourself.
You are on mute. Yes. Dr. Gandhi, you're on mute.
There you go.
Yes.
Thank you. Yeah. So 3 questions on a follow-up on this. Thank you very much. And it's a great lecture. And I'm a cardiologist by profession. And I always challenge these things to myself. Like, am I doing a good job as a cardiologist, heart failure, electrophysiologist with chronic kidney disease? So 3 questions is, like, as a cardiologist, when somebody has chest pain, I do a stress test. I don't put them in a room and do an EKG in a quiet room. Why do we measure hypertension in a quiet room when 90% of the time, if I have hypertension, I'm always in a stressful situation. I don't have a quiet room, and that's mostly applies to my patient. That's number 1 question in white coat hypertension. And why do we not change it to 24-hour or something better than a quiet room blood pressure measurement for progression of the disease? The second question I have is, do I contribute in patients progression from normal or subnormal kidney disease that I did not recognize because I'm treating most of the patients with creatinine, not looking at the GFR, not looking at their creatinine clearance most of the times, and giving them medications that can lead to CKD or procedures that can lead to insult like contrast nephropathy, short-term, long-term, leading to CKD. And the third thing is the most exciting branch, I think, in the future is renal degeneration, and what is its role with hypertension in general and in prevention of CKD or in treating blood pressure with CKD in the future. Too many questions, sorry, but I had these questions.
That's fine. So I'll start with your first question. You basically raise a point is that you are an interventional cardiologist. When you see a patient who comes with chest pain, you put them on a treadmill and you look at the chest pain and the EKG changes with stress. Why you are suggesting that we measure blood pressure in a quiet room and things like that? Well, we have 72,000 beats per day, approximately. And we don't even measure blood pressure once a day. We measure blood pressure once in 3 months. And yet we find a prognostic value in that blood pressure. It's almost a miracle that we sample so little of a measurement that happens with every heartbeat, yet we find prognostic value. So one thing is very clear is that all clinical trials have measured blood pressure at rest. They said seated blood pressure measured after 5 minutes of rest in triplicate. When you exercise patients, and I've actually done this quite a bit, I've put people on oxygen, measured the VO2 max and given them graded exercise and measured blood pressure while they're exercising. Blood pressure goes up dramatically with exercise. And when you actually stop exercising, the blood pressure falls, just like you have a heart rate recovery time. Blood pressure also has a recovery time. It actually improves and comes down to a plateau. Now that's going to be very complicated because if your patient, you're counting the number of measurements less than 130 as the gold standard, and the patient measures the blood pressure any time of the day they want, then some of those measurements will be after exercise. Some of them may be because they've just had a shouting match with somebody, and they'll be all over the place. So you want really a resting blood pressure because that's how we have always done. It's possible that the exercise blood pressure have a prognostic value, and there are studies that show that. The second question you ask is about the injury to the kidney and that you're avoiding medications that might injure the kidney. You're thinking that creatinine clearance and all might be better to look. But, Dr. Gandhi, if you really want to look at the patient from a kidney standpoint, measure a urine albumin to creatinine ratio. It doesn't even require a blood stick. It doesn't even require access to the vein. You just pee in a cup and you send it to the lab for urine albumin, urine creatinine. That ratio tells you about kidney injury. If it's more than 30, you know you have kidney injury. 30 to 300 is what we call A1 albuminuria, more than 300, A2 albuminuria, or very high albuminuria. And that's a patient who is as much at risk of contrast-induced kidney failure, cardiovascular risk, all-cause mortality, heart failure hospitalization, atrial fibrillation risk, risk of AKI, progression of kidney disease. There are at least 10 things that they are at increased risk of by simply measuring dipstick proteinuria. The third question you ask is about the denervation. Denervation is actually, there was just an approval by FDA on one of the devices. We talked about sympathetic activation. One of the slides that I showed you is that the kidney is a giant neuron. It's sending signals to the brain to increase blood pressure. And if we denervate the kidney arteries, you might actually have a lowering of blood pressure. And clearly, that may be something that we might be doing even in kidney patients. We haven't had enough studies in kidney patients because this therapy is just coming on board. But, we now know that if the patient is involved in their care and they measure the blood pressure, you can get beautifully controlled blood pressure, almost as much effect as you can have with denervation. There are other exciting therapies coming. For example, once in 6-month therapy with angiotensinogen blocker. So you give siRNA, you inject it, it blocks the angiotensinogen, and you call the patient 6 months later for another injection. So long-acting antihypertensive drugs targeting angiotensinogen. A lot of exciting developments happening in this area. But those are the answers to your questions.
Thank you so much. The next is from Dr. Alok Agarwal. Dr. Agarwal? Dr. Alok Agarwal? Okay, not
Actually, it's
No,
in the
no,
chat box.
he's trying to unmute himself.
Oh, okay, go
Yeah,
ahead.
he's trying to unmute himself.
Yeah.
Okay, I think I saw your question, Alok. I think you wanted to ask me, tell me an algorithm for blood pressure medication, right? Is that what you wanted to ask? I think somebody asked me that question.
I can frame the
Yes.
question. Yeah, excellent presentation. So I think what is important is hypertension control in proteinuric kidney disease. So number one question is the importance of all different lifestyle factors in decreasing the proteinuria. Number two is the medications. Number three, the goals. Number four, how do you counter the hyperkalemia?
Very good. So, we now have multiple medications in kidney disease to improve the prognosis of people who have chronic kidney disease. We start with the ACE inhibitors or angiotensin receptor blockers. They are the backbone in people with proteinuria, and they have been around, as you know, for many years, decades. The second medication that has become really important are SGLT2 inhibitors. SGLT2 inhibitors, whether you have diabetic kidney disease or non-diabetic kidney disease, at least you have more than 200 milligram per gram albumin in the urine, they are now shown to reduce the rate of progression of kidney disease, including dialysis and heart failure. So that's very important. The other two medications are limited to people who have type 2 diabetes and kidney disease. One is called finerenone, and finerenone can also reduce the risk of kidney failure and reduce the risk of heart failure, hospitalization, cardiovascular death, and myocardial infarction. The last medication is GLP-1RA agonist, specifically semaglutide, and that is probably only in people with type 2 diabetes and kidney disease. In the FLOW trial that was just published a few months ago, 1 milligram per week of this drug was associated with about a quarter reduction in kidney disease progression. So that can be very, very beneficial there. On top of this, low sodium diet will potentiate the anti-albuminuric effects of the ACE and ARBs. And if you add chlorthalidone on top of ACE and ARBs, they can further reduce proteinuria. Again, lifestyle modification like cessation of smoking, avoidance of non-steroidals, and healthy diet and exercise always have to be in the background. So those are the things that we generally talk to when we are talking to the patients.
Okay. The next question is about this point you made earlier, that if the patient is a diabetes and has a chronic kidney disease, but not necessarily the proteinuria, what will be your approach?
Yeah. So, the people without proteinuria and they have chronic kidney disease, they have other issues. For example, they are slow progressors. So kidney disease progression is not so much of an issue in them, or at least when we have tried to study them in clinical trials, we don't find much events in them. Yet, these people have cardiovascular disease, and they often will have cardiovascular disease much, much more than kidney disease. For example, if you look at a trial called Fidelio and Figaro, in total, they had 13,000 patients. The only 7% of the patients there had kidney disease progression, but 14% of the patients had cardiovascular disease progression. All these patients had CKD and type 2 diabetes. And so cardiovascular disease in a CKD population is twice as common as kidney disease progression. And finerenone was able to reduce the risk of heart failure hospitalization by a little bit more than a fifth, and going on dialysis by a little bit more than about a fifth. So, you can have situations where you can prevent cardiovascular disease in people who have little proteinuria, but that is also a very important factor. For example, if you have diabetes and you have atherosclerotic cardiovascular disease, then SGLT2 inhibitor might be the way to go, because we know from the EMPA-REG trial that it reduces the risk of atherosclerotic disease, even though those patients didn't have albuminuria. So same thing with the SGLT2 inhibitor, same thing with the GLP-1 RAs. They will be anti-atherosclerotic even in the absence of albuminuria. So CKD is simply a marker of having atherosclerotic cardiovascular disease, and those people succumbing from especially heart failure and atherosclerotic disease. So we still have to be careful about the heart. Kidney is fine, but you're treating the whole patient.
Excellent.
Okay.
The one question which combines role of diuretic. So can you just expand to where to use loop diuretic and when to go for thiazides and especially chlorothalidone?
Yes. So, the long-standing belief in nephrology has been that the loop diuretics are needed in people who have GFR less than 30. And if your GFR is more than 30, use a thiazide. But, we actually did a trial in people who had a GFR of less than 30, 15 to 30, and we gave them chlorothalidone or placebo, and we found a 10 millimeter reduction in ambulatory blood pressure monitoring within about 12 weeks. So chlorothalidone is a very effective drug, even in people with advanced chronic kidney disease. If you are treating hypertension, chlorothalidone is a great drug. The problem with chlorothalidone is the side effects: hyponatremia, hypokalemia, hyperuricemia, and flare-up of diabetes. So you want to use the minimum necessary to control blood pressure. And what is that minimum? In people with chronic kidney disease, we find that 12.5 milligrams once a day is good enough. If the patient is on loop diuretics, I cut it down to 12.5 milligrams 3 times a week, because that's enough to get the blood pressure down. If you give more, you'll just get side effects and acute kidney injury and things like that, rather than better blood pressure control. You still have to be mindful about potassium, and sometimes you'll have small decreases in GFR, but they usually will be reversible. What we find is with chlorothalidone, you have about a 50% reduction in albuminuria within 12 weeks, which is quite remarkable. A drug that hardly costs anything is so effective in reducing albuminuria. But in this trial that we did, everybody was either on a beta blocker or a ACE or ARB, so you have blocked the renin-angiotensin system, and then when you use chlorothalidone, it can reduce proteinuria quite effectively. Loop diuretics, more for heart failure. If you're treating hypertension, then use very, very tiny amounts. I start with like 10 milligrams of torsemide or even 5 milligrams of torsemide. And, even very low doses of these drugs can be quite effective. You go with higher doses, especially when you combine it with ACE and ARB, you're kind of risking kidney failure. Other classes, for example, dihydropyridine calcium channel blocker, like amlodipine, felodipine, long-acting once a day, they're pretty good. I tend to use atenolol quite frequently. And the reason I use atenolol, it costs a penny a pill, but it's actually excreted by the kidney. So in a patient with kidney failure, I can give 12.5 milligrams once a day and offers 24 hours control. I can't do it in a patient without kidney failure. But atenolol is not metabolized by the body. The only way it gets out of the body is through the kidney. So I can use a very tiny amount, and I know the patient is taking the drug because they almost always have a heart rate in the 50s, 60s. So I know that they're taking the drug. Okay. So those are the different strategies.
Yeah. One quick question, Rajiv. I'm just moving the age group to pediatrician. So Dr. Tirunagari, she is a pediatrician who sees stage 1 hypertension in quite a few adolescents on their annual physicals, frequently with high BMIs, renal function normal. In addition to lifestyle changes, what would be the recommendations for blood pressure monitoring? And another question related to that age group is that they say that this MI and cardiac arrests are common in young adults, young boys and girls, late teens, early 20s. They're under a lot of stress, college, jobs, how do we measure their blood pressure? And is it similar to mass BP? And what should be the cutoff for intervention in these young kids?
Amit, I'm totally at a loss to answer that. I work at the VA. My pediatric patient is 50 years old. So I'd hardly see any pediatrics, and I'm not qualified to answer those questions. You probably want to ask a pediatrician.
Pediatrician, okay.
Yeah.
Okay, Dr. Sharma, you want to carry on?
A lot of questions about COVID, young heart attacks. I think in context of young people having a heart attack in India or here, especially South Asian descent, there's a whole new discussion, and we will have another full talk. But based on my readings and based on my personal experience, this premature coronary disease and acute coronary syndrome still is #1 reason. I mean, we tend to have atherosclerosis at a very early age, and the shift of the risk factors going earlier and earlier. Generally, we have about 10 years earlier presentations, but because of the lifestyle, the stress, the addictions, I think the incidence of coronary disease and acute coronary syndrome and atherosclerosis in young Indians, whether here or there, is actually starting early, 30s and 40s. And COVID is also part of that problem, but the treatment and detection should be early. Of course, the teenage hypertension, we start screening early and treatment early, but also you need to detect the subclinical atherosclerosis is very important. We cannot rest on the conventional risk factors because those factors were populated and extrapolated from the Caucasian population. We need to get some kind of imaging modality. The whole world is going towards imaging, like just like a cancer of the breast or cancer of the prostate. If you see, you treat it. So recommendations are right now. It has not been accepted, but more and more people are adopting the approach of coronary calcium score on young Indians. That's what I do in my practice here. And when I go to India, just go to coronary calcium score. You will know it is there or not there. No matter what is your background, genetics, bad genes, lifestyle, LPA, whatever the problem is, if you see the plaque, treat it. And then just the visual appearance of the plaque makes people more motivated. And that is the gold standard is going to be happen very soon in the next few guidelines. But for South Asians, premature coronary disease, genetic factors, even COVID, family history, LPA, whatever, just get a scan at early age when you have no symptoms. And then you have a guideline to go and treat your cholesterol aggressively, diet, lifestyle, all the prayers and meditation, diabetes, everything is perfect. Everything is good. But one of the worst factors for progression of atherosclerosis and plaque rupture that causes premature heart attack is LDL. And now more and more studies on CTA are showing that the lower the LDL is the better. LDL in Indians should be about 70, but even 50, because that's where the soft plaque gets regression and you reduce the risk of a first heart attack. So I will stop there, but that's a whole new topic.
Hey.
Now, one more question, Dr. Agarwal, is about this aldactone MRA, not the Finenon, but the regular aldactone. Where does it fit? First line therapy, second line therapy, fourth line, where do you fit it? And especially when you're concerned about hyperkalemia.
Right. So aldactone is a great drug. It's a very potent antihypertensive drug. And it's a fourth line therapy. And essentially, it's the #1 drug for resistant hypertension.
Yeah.
So if you are taking ACE or ARB, you are on a diuretic and a CCB in full doses, and your blood pressure is still poorly controlled, that is the way to go. Now, both the European guidelines and the American guidelines, they tell you that you have to be cautious if the potassium is more than 4.5 or GFR is less than 45. Because the trials, the Pathway 2 trial that was done in the UK was seminal in establishing the place of spironolactone for the treatment of resistant hypertension. They excluded people with hyperkalemia or people who had low GFR. So that's a dangerous situation to be in. We did a study and we asked the question whether we can enable the use of spironolactone by using patiromar, which is a potassium binding resin. And what we found was that if you gave spironolactone to people with chronic kidney disease, these are all patients with CKD, we found 2 out of 3 will get hyperkalemia within 12 weeks.
Mm.
But even when you use Patermar, 1 out of 3 will get hyperkalemic. So I don't think that is the answer, because Patermar itself is quite expensive. And what if you forget taking Patermar and you are taking spironolactone, or your insurance says, no, we have given you enough Patermar, you can continue to take spironolactone? Where do we land with that?
Yeah.
So hyperkalemia is definitely an issue with that. And in CKD, be very careful because hyperkalemia is really common in this population.
So one more question about on that context. One of my friend called me a long time ago about this phenomenon, is approved by FDA. So is it risk of hyperkalemia is much less than aldactone and a usual, or this is something safer or the same risk?
Yeah, so I was on the steering committee of all the finerenone trials that were published in New England Journal. I think it's very important to recognize that finerenone is a non-steroidal MRA. It's not spironolactone. Spironolactone is a drug that is a prodrug. It's metabolized to candrenone, and candrenone is metabolized to 6-methyl-spironolactone, and 6-methyl-spironolactone is further metabolized to others. So it has spironolactone. When you give it, it'll have kids and grandkids, and all of them will live in your body. And the grandkids have a half-life of 1 week. So 3 weeks after you stop spironolactone, the drug is still there in the body. And that's why it's so effective in lowering blood pressure, because it really never goes away. Finerenone has a half-life of 2 hours and has no known active metabolites. So it's really short-acting. Yet when we do ambulatory blood pressure monitoring, 10 milligram dose will get your blood pressure down about 8 millimeters. A 20 milligram dose will get it down about 10 millimeters. These are people with chronic kidney disease and type 2 diabetes, all of which had microalbuminuria. So we did an ambulatory blood pressure study. It gets the blood pressure down. The problem is that when you compare it to spironolactone, it's not as potent as spironolactone. Spironolactone will get your blood pressure down 14, 15 millimeters of mercury, but it's a lot safer for hyperkalemia. Hyperkalemia incidence with finerenone will be very, very rare. And I just told you that even unprotected spironolactone, 2 out of 3 people will get hyperkalemia within 12 weeks. In the clinical trials we did, 14% of the people got hyperkalemic with a median follow-up of 3 years. So 14% median follow-up of 3 years versus 67% within 12 weeks. So spironolactone, finerenone, there's no comparison with hyperkalemia. The proof of the pudding is when you start using the drug. I probably have used it quite a bit. You hardly see any hyperkalemia compared to spironolactone. So very different drugs. The price of finerenone is many, many times that of spironolactone. Hard to get the drug, but it's really indicated for cardiorenal protection in people with type 2 diabetes and chronic kidney disease.
Excellent. So one more question about African subset. Does your algorithm change? Do you start with the diuretic or calcium channel blocker? Do you treat them differently, or the same algorithm for resistant hypertension?
Say that again. Which patients?
Afro-American.
African Americans or non-African Americans. We are basically, they're all the same. I think we use that race as a construct, but if you have albuminuria, you have to put them on ACE or ARB first. You still have to protect the kidney. And in the African Americans, I've talked briefly about the APOL1 mediated kidney disease, and there are now trials that are going on for drugs that will block APOL1 mediated kidney disease. It was inaxaplin is the name of the drug. It was published in New England Journal a few months ago, and it was a phase 2 trial, encouraging results. We're now doing a phase 3 trial looking at the same population of African Americans. If you do genetic screens on these people, you find that a fair number of African Americans, they simply don't have kidney disease. They have APOL1 mediated kidney disease. So in the future, once we have therapies, you'll have more sort of genetically guided therapies in these patients that will be able to reduce the risk of progression to end-stage kidney disease, which is enormous in these individuals.
Okay, Dr. Kathula, do you want to continue for a few more questions, or you want to?
I'll just ask
We
one
have
question.
a couple more questions I think we can do.
Okay,
We can answer because I don't, a lot of people stayed back actually.
please go ahead.
Talking.
Yeah. No, Rajiv, one quick question. Again, this is more of, I don't think we have an answer, but just as a future of hypertension therapy, where do you see the role of vaccination? Because there are preclinical trials on angiotensin II vaccines. And is that something that you believe could be the mainstay treatment? People just get vaccinated for these and maybe not see hypertension at all?
Well, they are not so, vaccination was a concept that was proposed at University of Florida, Gainesville about 20 years ago. But now we have more drugs that are going to block the angiotensinogen using mRNAs and things like that. So siRNA technology, you give it once a month and it blocks the effect of angiotensinogen. The clinical trials are ongoing. Name of the company is Alnylam. They are doing clinical trials with this. The issue with this is that if you block angiotensinogen long-term and say you come in septic, how are you going to protect your blood pressure because you don't have angiotensinogen anymore? Or, you need angiotensinogen and you don't have it, then you get, if you are on ACE or ARB, what do? We just stop the drug. Here you have basically rolled the dice, and that dice is not going to be unrolled for the next 6 months. But, luckily now we have angiotensin II infusion available. We probably will get antidotes, and the clinical trials can only tell us if this is a concern or not a concern. For example, we thought that stopping ACE or ARB prior to surgery might be a great thing. But just a few weeks ago, there was a clinical trial published in New England Journal that shows that whether you stop ACE or ARB or not stop ACE or ARB, the outcomes are the same after the surgery. So, what we think is obvious, or what is we think is going to be the case, we might not find in a clinical trial. I think therapies like angiotensinogen block may be something more futuristic. There are other agents that are in development. For example, baxdrostat is an example. It's a aldosterone synthase inhibitor. And earlier we really didn't have agents that could block aldosterone synthesis because they block both cortisol synthesis and aldosterone synthesis. But now the chemists have become very clever, and they can specifically target aldosterone synthase. And there are 3 or 4 drugs in the pipeline looking at aldosterone synthase inhibition. So I think that there are other drug. There's another drug which is the aprocitentan. Aprocitentan, which is Idorsia is the name of the company that makes it, and also effective antihypertensive. It's still a branded antihypertensive. Probably would have to have challenges getting it to the insurance, but it can have good antihypertensive effects. And this is one of the new antihypertensive agents that was just approved by the FDA in the last couple of years. So a lot of activity happening in this space. The endothelin receptor antagonists, aldosterone synthase inhibitors, what we talked about is angiotensinogen, siRNA technologies, and of course the renal denervation. Those are all ways that we can do things. But as we talk about the latest and the greatest, I think just involving the patients and telling them you're not going to feel the symptoms till you come down with a stroke, or you have a heart attack, or you come down with heart failure. So this is like an oil change. You have to monitor the quality of your blood pressure on a regular basis so you can stay out of trouble. I think that involving the patients is really important, and having a validated home blood pressure monitor to do this, which is plenty available in this country, still hard to find in India. So for example, if you try to find which of the 50 monitors in India are validated, it's almost impossible to find, because you go to the website and you say, is this model validated? No answer. Is this model validated? No answer. So it's, you end up with Omron or something like that out there. And it's hard, especially when you have more than 1 billion people living in that part of the world. What do you advise them? How do you monitor blood pressure in those individuals? So I think we still are in challenging times in terms of long-term control of this silent killer. As Dr. Sharma said, this is a global burden, and to have a global response, to have a global solution. But it all starts at home. You have to see what you can do for your patients and spread it from there.
Great.
I have one more question if you have time.
Sure.
Practically speaking, we deal this all the time. There's one question about how do you manage this labile hypertension in people with dialysis, off dialysis, day of dialysis, in between. It's very challenging. Any insights from your long experience?
Yes, I write this section in Up to Date on hypertension and dialysis. If you want to read that, that will give you the detailed version. Blood pressure, by definition, is going to be labile in a dialysis patient, because what you're doing in 4 hours is what your kidney does 24 hours a day, right? So you do it in 4 hours, you're removing fluid in 4 hours, and your kidney takes 48 hours to remove the same amount of fluid. So blood pressure is going to, from a shock level to very hypertensive level. The trick is, how do you keep it under control over a long period of time? And the best we can tell is that it's not the use of medications, but instead of the kidney that serves as a volume marker, the dialysis doctor now is serving as a volume marker. He decides how much fluid to remove and how much fluid to keep on the patient. And I can tell you, the stupidest kidney is smarter than the smartest kidney doctor, because we have no idea. It's a trial and error. We basically will remove too much sometimes. We will give too much sometimes. But the important thing is to admit to the patient that, look, I want to keep you without symptoms, but also keep your heart healthy, and so you don't come in for an emergency dialysis or you don't feel really bad at home. And what is that level of volume is something that you have to engage with the patient and see what is the level, the lowest level of volume that they will tolerate without symptoms. And home blood pressure monitoring is invaluable in these people.
Excellent. There's one, Sarah and Prem have raised their hand. Please go ahead.
You are on mute, Sarah.
Sarah, you are on mute.
If you unmute yourself, you can ask the question.
Thank you. Yeah, I got it unmuted now.
Yes.
Question about SGLT inhibitors, and so use of that in CKD. When do you decide to stop it? Because once the patient starts having dialysis, so then it's going to be hard to. Do you continue after they start dialysis to have the cardiac benefits? And if so, SGLT inhibitor side effect is normoglycemic DKA, but you're clearing up all the low bicarb with the dialysis. So how do you detect it? So my question is whether you continue SGLT inhibitors once they get to dialysis to have the beneficial effect on the heart.
Very good question. So, I chaired the adjudication committee of the Credence trial, and the Credence trial was the first trial that was established the use of canagliflozin for the treatment of type 2 diabetes and chronic kidney disease. It was the first trial that showed 28% relative risk reduction in kidney disease. It turns out that in that trial, we stopped the drug once the patient reached dialysis. The threshold, as you know, you can't start the drug till the GFR. If the GFR is less than 25, you shouldn't be starting the drug. But if you're on the drug, keep going. But if the patient goes on dialysis, you stop the drug because there's no evidence that it is protective. Having said that, there's a clinical trial going on in dialysis patients where they are randomizing dialysis patients to the drug or placebo. Time will tell what that trial shows. But I do not use the drug in dialysis patients. If I find that the patient is on SGLT2 inhibitor and on dialysis, I stop it. The reason is quite simple. SGLT2 inhibitor receptors are not found in the heart. They are present in the kidney. Just like diuretics don't work in people who are anephric, SGLT2 inhibitors wouldn't work in people with anephric. I could be wrong, but this would be proven by the clinical trial that's funded by AstraZeneca that's ongoing. It's a basket trial looking at dialysis patients also. So a few years you should have some answers, but I don't use it for the same reasons you pointed out.
And other question is, once you start SGLT2 inhibitors, do you adjust the diuretics because of the tubulo-globular feedback, and it itself is acting like a diuretic, right?
Yeah, true. Most of the times it's not needed. They are weak diuretics. You lose about 1 kilo or 2 on average, but a lot of it is the caloric loss. You lose about 300 calories per day. So some of it is sodium loss, some of it is fat loss, but normally we don't, unless they get hypotensive, in which case you back off the diuretic. But in my practice, I've not needed to adjust the diuretics because I've added SGLT2 inhibitors. Now, I almost never use 25 milligrams, just put them on 10 milligrams. That's the cardioprotective, renal protective dose of these drugs. So I'm not using them as anti-glycemic agents. And anti-glycemic effects are very, very weak once your GFR is very low, because they're not really wasting as much glucose. If you want anti-glycemic effects, it's better to use GLP-1 RA because they still retain the anti-glycemic effects in people with kidney disease.
Thank you very much.
Sure.
So we have one hand that is raised. That's the last question because it's 9:20 already. Khalil Rahman, let me unmute you.
Yes. Khalil, if you unmute yourself, you can ask that question.
Yeah, can you hear me?
Yes,
thank
yes.
you. Wonderful. Amit asked me to join you guys, and it's just amazing. The question I have is, I know we don't take care for, we don't address that much of low blood pressure, which is the diastolic blood pressure. We get phone calls from the dialysis, this is 40 and diastolic and 30 diastolic. What is a low diastolic and where do you intervene? Because we don't intervene with a low diastolic blood pressure. So,
yeah, I don't either. I'm like you. I basically say thank you for calling me, and it's okay, because we don't have drugs to change diastolic and leave the systolic alone. There's no drug that will only selectively dial up the diastolic, and if there was a drug, it would then have to stand the test of time that shows that it's cardioprotective. There's no question about low diastolic being a cardiovascular risk factor because it's a widened pulse pressure. You have a stiff arteries, and therefore you are at increased risk of cardiovascular outcomes. All the isolated systolic hypertension trial, CIS China, CIS CIS Japan, they all showed the same thing, that for a given systolic blood pressure, a low diastolic is a greater cardiovascular risk than a higher diastolic. But we don't know how to raise diastolic, so you just keep going. The American Heart Association guidelines, and this is from way back, they say in people who are older than 50 years of age, the target of treatment is systolic hypertension, not so much diastolic hypertension. And that's what we ought to focus on. We recognize it's a cardiovascular risk factor, but you don't try to stop medications, etc., to improve cardiovascular risk because there's no data to support that practice.
Thank you, Dr. Agarwal. Appreciate
last
that.
question, Satish, one question, just 30 seconds. Now, there's an entity called a barrel reflex failure. Do you have any magic
Yeah,
approach.
I have a magic thing. You have to introduce that patient to Elon Musk so they can go in space. When they don't have gravity, baroreflex won't have a problem.
Okay.
Space travel. Gravity is not your friend on this planet.
Okay. Good enough. Okay, Satish, I'm done. You take.
Thank you, Dr. Sharma, for moderating. Thank you, Amit.
My
Thank
pleasure.
you, Dr. Rajiv Agarwal, and thanks all the attendees who attended today. So we'll have another session coming up in September 25th. So every other Wednesday, we are planning to have these webinars, and hope all of you join. And we have a virtual plot presentation for Dr. Rajiv Agarwal. Ms. Vijay, can you put that on, please? So can you blow it up a little bit?
Oh, perfect.
So let me read that. American Association of Physicians of Indian Origin recognizes Dr. Rajiv Agarwal for his outstanding contributions in the field of medicine and welcomes him as a member of AAPI Distinguished Speakers Club. Satish Kathula, AAPI President, Amit Govil, Chair, AAPI CME Committee, September 12, 2024. Thank you, Dr. Agarwal, for the excellent talk. And again, so we like to see you again this year sometime. So thank you.
Thank you, Amit, for inviting, and
No,
thank you to
great.
all the
Thank-
participants who had just wonderful questions and very gracious. Thank you for your comments.
Thank you.
Thanks a lot.
Thank you.
Thank you. Excellent start.